Okay. All right. Well, good evening. It's 7:02 in New York City. It's a beautiful late spring, early summer day. It's still not humid. The weather is perfect, sunny on a fine breeze. Barely a few minutes ago, you could hear people cheering outside, the healthcare workers and the primary responders. I hope wherever you are, you're happy and healthy and not affected by all the events around us. It's definitely, whoever wished to live in interesting times, definitely their wish came true, because we are living in interesting times. Today, we have a great session. We are very fortunate to have a special guest, Dr. Randy Weber from MD Anderson, Dr. Kevin Emmerich from Mass Pioneer, and Mike, who's your guest from Stanford?
So Ann Chang, who's leads the high-risk cutaneous malignancies program there. So yeah, thanks so much.
All right. And Dr.
Sure.
Chang from Stanford. So we have an all-star lineup. We are going to take a few minutes at the end to say goodbye to our current fellows who finished fellowship and go into better, higher endeavors. All right. So without further ado, let's just start. I think Dr. Moore is going to start.
Sure. Yeah. Thank you. Let me click this on here and I'll share my screen. Let me see here. Is that showing up, guys?
Yeah.
You guys hear me all right?
Yeah.
All righty. So this is relatively, hopefully, bread and butter, but a couple of management questions along with it that I'd like to get the thoughts of the participants on. So this is an 82-year-old gentleman. He's a retired professor from a local university who presented for a recurrent right parietal scalp cutaneous carcinoma. He had an attempt initially at removal by an outside Mohs surgeon who had cleared the peripheral margins, leaving a total defect of a little over 2 centimeters, but it had been sent down with the positive margin on the deep near the periosteum or possibly at the periosteum. He had a history of many other cutaneous scalp squamous cell carcinomas and pre-malignant lesions. Many of them have been previously removed. But he noticed this one was bothering him much more than the others. He had had some minor trauma, bumping his head near it, and he felt like that was kind of the nidus or what started it, but difficult to say. And so ultimately showed up to us with the path report of a positive deep margin. At that time, there was no obvious palpable parotid or regional nodal disease appreciable, and we did a formal re-excision. I went ahead and re-excised the peripheral margins and then removed the periosteum with the goal of, we had discussed the option of doing an outer cortical craniectomy and planned integragraft placement at that time. And so he, at the time of his re-excision by me, even though the peripheral margins were clear, he did have an area of initially a positive margin that we re-excised at the time of my initial surgery. But I bring that up mainly just to show this appeared to be a more aggressive than the average cutaneous lesion. Because of that, I'd talked to him about the option potentially even of doing a more definitive reconstruction and whether or not there would be any role for consideration of adjuvant therapy. It was found to have perineural invasion and a poorly differentiated cutaneous lesion. So I guess before I go to the next portion of it, why don't we just stop there and see how would people have managed this, even this first portion, any differently, any other steps that you would have taken.
So you had perineural invasion in your resection part?
Yeah, in the small bits of it, basically, I think the area that was quote unquote positive at the peripheral margin when I did the re-excision just to kind of freshen the edges, it looked like it was most likely along a little nerve branch.
Okay, well.
That peripherally, but obviously.
All right. I think Jeff is online. Jeff?
2 questions, Mike. When you did your re-excision, what kind of margins, like how far further out did you go out just to help frame it?
No, that's a good question.
And the other question was just imaging, whether you had any imaging either now or before to sort of comment on.
Yeah, I did, just to assess I did a CT of the head and neck. So looking on the coronal plane to assess the calvarium, seeing no, cortical irregularity, and also just to look in the parotid and the neck, just because it did show on the primary lesion a poorly differentiated, behavior, and in reality, he was a bit of a difficult exam by palpation, just to make sure I wasn't missing something hidden within the parotid.
Okay. So non-healing, persistent cancer after 2 rounds of excision, perineal invasion, cortical bone intact, and imaging. Jeff, what would you do?
I would just start with re-imaging at this point. I think that I think it's really important to understand the relationship to the bone. I would also consider an MRI. I've been fooled sometimes. You can see sometimes with a CAT scan, gets to the way they angle it, you don't really see the scallop. You've seen like minimal scallop, and you're like, oh, it doesn't look too bad. And then you get the MRI, and it's very clear there's marrow infiltration. And it's sort of like an inverted mushroom. It kind of like goes down and then bulges out. So I think I would get a CT and MRI again at this point and assess, and then probably talk to a neurosurgeon, because at this point you've definitely gotten to the bone multiple times, and it's inadequate in that direction. And so I think a calvariectomy is a consideration, and I prefer to have someone licensed to go to the brain with me on those kind of, when there's a plan for that.
Do you plan to take the outer table or both tables?
Well, it seems like, with the prior resection, you were already at the periosteum in the outer table. So I have to see what the imaging shows, but that's why I think having a neurosurgeon is really helpful, because a lot of times I think at this point when you go back, I think it's very likely you're going to see at the minimum some sort of outer table erosion that wasn't picked up in the CAT scan. As you guys know, it's always worse than the scan. So even if you see minimal, you'd rather be over-prepared than find yourself staring at dura and not very happy about it with no backup. So,
Kevin?
Just if I can go back real quick a little bit. Mike, anything else on his history? Is he immunocompromised? Has he been using any topical treatments in that area? Is he using Efudex or anything else?
Yeah, very good question. So he's not immunocompromised. He has had a significant sun exposure history, and by looking at his skin, I feel like he certainly is predisposed to this to some degree. And I think it's just probably a combination of his prior sun exposure and age, but he did not have an underlying immunosuppression.
And then, I think it's important to note, because you said that the Mohs surgeon felt like they had cleared the peripheral margins, correct?
Correct, yeah.
And then you went and took some additional tissue for clearance, for cleaning up, and found tumor. And I think it's important to recognize what you're telling us, which is that with frozen section, Mohs or otherwise, may not be the best way to see this tumor, whether it's the perineural component or whether it's the poorly differentiated component. And so I think for the fellows thinking about different ways of getting a complete, comprehensive peripheral and deep margin assessment, which for most people means Mohs, but for us as head and neck surgeons, we want to think about taking en face margins, but engaging our pathologists and getting en face margins with, permanent stains, being able to use immunohistochemistry when we can, or permanent sectioning, sorry, because this is a great case that tells you this case was destined to recur after Mohs when you can't see it well. And then don't think you can rely on frozen sections when you go back to take more. I think that, for me, as you were talking, was one of the, big teaching points to think about.
Okay. So in terms of
thing is they can search around for, I'm sorry.
Go ahead.
I was going to say, this is Ann Chang. I'm from dermatology. The other thing is you can search around if you're doing H&E for the actual nerve caliber of the pathology of cancer that involves the nerves, because you had mentioned there's only one small caliber. I didn't get the diameter, but it's a consideration for adjuvant treatment after pre-excision.
Great point. Sorry if sometimes I might rush people. As you know, we have 20 minutes for each case. We are already at 13 minutes here, so we got 7 more minutes. All right, a great point about the size of the nerve. I completely agree, and actually we have decided that all the perineural invasion has to be described by our pathologist, the size of the nerve. So in terms of management, Kevin, what would you do now?
Definitely imaging with both, with CT, potentially I can't quite see where we are with respect to midline, but a CT and a CTV. I want to look and see if the sagittal sinus is flowing. I agree with Jeff. I think an MR can be helpful here too, depending on what the CT shows.
Okay, Dr. Weber?
Yeah, clearly you have to image this patient. The CT will inform you about the status of the cranium. Also, an MRI is complementary. It'll give you some information regarding transcranial invasion, dural enhancement, and help you plan your surgery better.
Do you routinely get MRI on your patients nowadays, Dr. Weber, if you have a recurrent patient?
Yes.
Okay.
Yes.
All right. So let's summarize this part. So everybody agrees that needs to re-imaging, don't get fooled, don't rush the patient to the OR, or don't try to take it out in clinic. This is a little bit more involved. All right. Any other comments at this part?
Yeah, this is also a good time for a multidisciplinary discussion and to bring in your whole team that helps take care of these folks to start getting to know this patient.
Yeah, I completely agree. Fantastic point. Okay, Mike?
To that, I would also consider imaging the parotids and the regional neck lymph nodes, just given the recurrent.
Would anybody advocating for a CT get a PET CT?
I might start just with a contrast-enhanced CT of the neck.
Okay. So the point is, really PET CT not going to help you with the primary lesion because the brain going to light up in the entire part. For the parotid, it's a good question. Routinely, when we do PET CT, we do the neck separately with the contrast. All our PET CTs are done with contrast, so we have that extra benefit. But in general, if you don't want to get PET CT in this sport, I don't think you're going to miss that much. All right, Mike, you're up.
So yeah, just before I go through the imaging findings, I think an important point, and Kevin highlighted the importance of the multidisciplinary discussion. Thinking about that going into your surgery, I think is important as well. So on a patient like this, where this is a bit more advanced now, where it's involving the full cortex, but if you're considering something like just a re-excision, outer cortical craniectomy, and there's no obvious regional disease, and you're hoping that that will be the extent of your primary surgery, the reconstruction you use, if you know you're going to need adjuvant radiation therapy, using something as straightforward as Integra can sometimes put you at risk for radiation necrosis. And so that was a big part of our discussion. The way this one, if you will, kind of looked and smelled, just the appearance of how it was behaving to me made me think he was going to need it. He had his own mindset of what he was willing and not willing to pursue, which has unfortunately kind of walked us down a challenging clinical course. But I will say you need to have that discussion before anything. And sometimes you can use Integra with the idea you're going to get your final margins. And then if it turns out you're pleasantly surprised, you can always go back and leave that and just do it as a skin graft over or let it granulate. But if you know that you may have to go back and more formally address it, then you could go back and do a free tissue transfer.
Yeah. I think that's a great point. And I would go one step further. Every time I have done a skin graft on bone and the patient got radiated, I regretted it. Almost always.
So here, just in the interest of time, you can see the outer cortical defect. Obviously, some of that could be related to the prior surgery, but you have to consider that the full thickness of the bone is condemned at this point. No obvious intracranial extension. There was an MRI done showing some dural enhancement, no obvious nodularity. This here was actually a bridging vein. I kind of showed an additional cut here that shows kind of as the vein kind of tapers off. And it is lateral to the sagittal sinus, but you have to at least have that discussion, and that may be an area that you would have a challenge in clearing the margin if it was having like a dural tail going along towards the sinus itself.
So for everybody's on call, you can see how much added information the MRI would give you. And as Dr. Weber mentioned, we almost routinely get MRI in these cases. And look at the difference here. You look at this MRI, almost anybody agrees that the entire bone is condemned. At the same time, you're not too worried about the dural. So that really gives you information on how to manage this case.
Mike, if I could just, we don't have the full images to review, but did the CAT scan give any sense that the cancer extended to full thickness, or it was only as deep as those images you showed previously? And it's clear there's some sort of below the clinical threshold of detection for imaging to show that it's really gone deeper.
Yeah, this was about the most impressive CT cut that I had here. And so
I don't know that.
there's a
I don't
component
know.
of it that's much more aggressive in its behavior than the appearance on imaging.
Yeah, I think you have to assume the entire cranium's involved at the site of that ulcer. So I think the MRI is contributory, but this needs a full thickness craniectomy and possibly dural resection.
Perfect. All right.
So, and I think, I guess one point before I go to the next management question is one of earlier on in a recurrent scalp lesion with perineural invasion, poorly differentiated disease, no obvious regional adenopathy. Would anyone consider doing a sentinel node for this patient? Obviously, this location could drain, not, it's not on the vertex of the scalp, but could drain obviously in pretty wide variation. So bring us up to the group and want to get everybody's thoughts.
I wouldn't do a sentinel node for this, but I would agree with good imaging of the regional lymphatics.
Okay. Kevin?
I would think about this patient from the standpoint of he's got probably a 20 to 40% risk of regional metastasis. And there's certainly watching him is important. Watching him doesn't mean you're not thinking about the lymph nodes. I think if we decide not to do a sentinel node biopsy, then it's really important to image this person at least every 3 months in hopes of detecting that whenever it first shows up. For me, I would do a sentinel node biopsy, but I think the important take home is that this person had a high risk of regional metastasis and potentially distant metastasis with the bone invasion. And they need really close monitoring of those lymph nodes at least every 3 months. There's no doubt there's going to be some logistical stuff that might also play into that decision about sentinel node biopsy, but purely from a disease standpoint and what you described, this person's at a high risk of having an occult lymph node metastasis.
I would echo Kevin's concerns. I've had a couple of these guys that look fine on initial imaging, and then 6 months later they pop up with a parotid met, and you wish you had found it. And I've tried sentinel node on a couple of these. The problem with these scalp lesions often is that there's such a wide area that when you do 4-quadrant injection, I find the specificity of that sentinel node can often, especially with the vertex lesion, you get lesion, nodes that light up on both sides. And so it's a tough sentinel lymph node biopsy to do. So, so I agree just with, addressing the lymphatics in some manner. I think sentinel lymph nodes are appropriate for a smaller lesion, if not close observation, and certainly very fine cut imaging.
Yeah, I think the data is very mixed, and this is a challenging question. I think one of the things to keep in mind that unlike melanoma, where we do a lot of sentinel, where sentinel is like standard, the ability to control regional disease if the patient mets out is better than say melanoma, where when you have a stage 3 melanoma, it's a whole different ball of wax. So I'm usually leaning away from sentinel lymph node in my practice, but I certainly work with other individuals who would be more pro for a sentinel lymph node for a case like this.
I personally, redo, especially squamous cell. I doubt that sentinel, because you already had 2 excisions. The lymphatics have already been changed. Not sure if I would trust that. I completely agree that this is a high-risk disease and needs to be monitored. I'm not sure. I would echo what Jeff said. I can't blame anybody who does sentinel nodes, but I'm not sure if we have enough data to recommend it as something that could be done with it. Dr. Chang, any points from the dermatology literature for squamous cell carcinoma sentinel node?
Yeah, at least at Stanford, we don't typically do the sentinel lymph node for these kind of patients, even though they're high risk. I do agree with imaging, CAT scanning the neck as well. And if there's something lights up, then maybe a PET.
Yeah, okay. Mike?
Yeah, we had given a recommendation similar to what Dr. Weber had described. So formal wide excision, craniectomy, and reconstruction with consideration of adjuvant therapy, obviously assessing the dura intraoperatively and be done with neurosurgery. He was not interested in that, which was similar to his prior discussions with me about the management of this lesion. He was much more conservative in what he was willing to pursue. And so, I certainly then, had him visit with our medical oncologist, and I'd be curious to get Dr. Chang's insight on if this patient were to present to the high-risk cutaneous lesions clinic, what could be offered to them.
Yes. So our group is part of the pivotal trials for using PD-1 inhibitors immunotherapy for patients with locally advanced cutaneous squamous cell carcinomas. This guy certainly seems like he has that, if not more. So basically, it kind of boils down to is he a good surgical candidate? Is he motivated to get surgery with neurosurgery input? I agree that it's suspicious on the MRI that there's possibly dural involvement. And so if he's not good at follow-up, or he has some autoimmune condition that would make him a bad immunotherapy candidate, he's a transplant patient, things like that would turn him away from using something like immunotherapy. But if he is not interested in surgery, given after he understands the morbidity, potential morbidities, then he would be considered for immunotherapy.
And that would be Similivimab or the other. Do you have a preference?
Yeah, so that's the only one that's FDA approved currently. And so for insurance reason, that's the easiest to get. But we do have patients getting PD-1 inhibitors, pembrolizumab, for instance, off-label through their insurance.
All right, Mike, what did you decide?
All righty. Well, he ultimately elected to pursue Similivimab, and he's starting that therapy probably this week, actually. So.
Oh, so you don't have results yet?
Yeah, no. I don't have an outcome. And unfortunately, with this round of fellows, I'm not going to be able to provide that. I know we're rushed for time, so just to mention, locally advanced recurrent cutaneous squamous cell. You really have, want to be definitive in your next approach to their management. Surgical resection, there's obviously some consideration of sentinel nodes for the reasons discussed, but there's not strong evidence to sway us in that direction currently. And then certainly considering adjuvant radiation therapy for advanced tumors or high risk features. For scalp lesions, when they do appear to be involving the periosteum, you want to consider CT, and if there's true concern for frank bone involvement in MRI to look for intracranial extension and or perineural invasion. We didn't really go into scalp reconstruction, so I'll just kind of skip through that. And then appreciate Dr. Chang's insight on Similivimab and its role in management of these patients, either those that are surgically unresectable or those who are not willing to pursue that route.
Great. So in the interest of time, we got to move on. We have 2 more cases, but thank you. This is an excellent case for the fellows. This question is going to keep coming up. The Similivimab or PD-L1, with all these patients going to come to you and ask us, can we do this? Can we do that? My only advice is go by the guidelines, try to enroll as many patients as you can in clinical trials to be able to answer this. This is the challenge of our time. Okay, Arno?
Can I make one comment? Yeah, just the Similivimab, you can see dramatic involution of tumor with some of these PD-1 drugs. And we recently had a patient who had a through and through, so it was through both cortices. And the tumor involuted, and all of a sudden we had a communication with the dura and pneumocephalus and basically complications from that. So though these drugs have these dramatic results, you need to think kind of one step beyond that often and be ready with a management plan should you get that response you desire.
Can you bring up your presentation? I agree. There's a lot of unknowns.
All right. So here is my case. Do you guys see that?
Oh, that's a juicy one. Okay.
I think we've all seen a couple of these.
Yeah.
So this is a gentleman I've been following for some time now. He's an otherwise healthy guy, history of working in agriculture, lots of sun exposure, ulcerative lesion in the medial canthus, had been there for about 1 year when I'd seen him. So a closer look at the lesion, kind of raised borders. The lid was mostly closed. His vision in the eye, we had him seen by ophthalmology, was actually largely intact. 20/40, it was comparable to the opposite eye. Extraocular motions were restricted, though, particularly in lateral gaze. He was complaining of some epiphora. and he had no sensory complaints. We did a punch biopsy at the periphery of the lesion that demonstrated a basal cell carcinoma.
Excellent case. So in the
just
interest of time, let's go through the imaging, because we all agree that this probably needs a CT and MRI.
yeah.
Anybody would not do an MRI here? Okay, let's go.
So I'll just briefly show you, yeah, the MRI scans. Basically, it shows two different cuts. This is a T1 fat-suppressed GAD-enhanced image axial cut that shows basically this ulcerative lesion extending from the medial canthus into the lacrimal apparatus. It extends into the orbital fat and seems to displace the orbit superiorly and laterally. The globe itself appeared to be intact and was not invaded on this imaging. There was no concern for perineural spread.
Extraocular muscles?
So I think that the medial rectus looked like it was probably involved. The remainder of the extraocular muscles seemed intact.
Okay, so let's go around and ask folks. Dr. Chang, we'll start with you today.
Yeah, so, right. So we've been using hedgehog pathway inhibitors almost for over 10 years already for locally advanced basal cell carcinomas in carefully selected patients in close collaboration with ENT and ophthalmology. Their response rate is probably about 40%, with the idea that you can try to spare the globe and spare them a large defect on the midface potentially. But it again depends on whether they're going to follow up, because these are basically cases that would take months and months, if not years, to treat with hedgehog pathway inhibitors. So that's a lot of hand-holding through the side effects. If they're not going to follow up, or they have comorbidities that they're not going to tolerate the side effects of these drugs, which are basically GI side effects and musculoskeletal side effects, then they should just go to surgery. The other idea is we've been trying to use it in the neoadjuvant setting. So trying to shrink it to the point that we can salvage the globe. And we've had a couple cases of that working with Andrea Kostler that we're going to try to present a case series on that. But certainly, it is, it's good to have that option, that non-surgical option, but it's not for everybody.
Okay. But this is a patient that you would consider to start a hedgehog inhibitor, de novo.
I would, yeah. I mean, understanding that he's well enough to take those drugs.
Sure.
Yeah.
Okay. Any other comments here, Jeff, Kevin?
I actually have a question for Dr. Chang. I've been sort of more con on the hedgehog inhibitors for resectable curable basal cell carcinoma. I think its role in certainly regionally advanced metastatic is very well accepted and like unresectable. I just have a question for Dr. Chang, which is that my understanding is if you have an excellent response, when you want to go ahead and do the surgery, sometimes you're not really sure where your margins are located. And so I just wanted to ask whether or not in the neoadjuvant setting, whether or not you've been able to clear those margins, feel good about it, and whether it's been effective and durable, or it's more of we get a response, we're not really, but the margins are difficult to assess at the time of surgery. Because I would rather resect something where I know where the edges are, rather than try to estimate where I think they might be, or hope that they might have retracted away from the globe and sort of, because you're not going to be able to see it grossly, so microscopically you can get burned on the back end. So I just want to get, if you can provide some context.
Yeah, no, they need very close monitoring. So there's two kinds of resistance. One is that the tumor never completely regresses. And then the second kind is where the tumor apparently is gone. And we've had many of these cases gone on imaging, gone on physical exam, but then, a year or two later it starts to recur. And so that's another kind of situation where what do you do next? Because we do know that these tumors get resistance, they evolve resistance genes. And so it is more challenging surgically. And so that's why it's a multidisciplinary consideration. In this patient, do you feel like, I actually don't know, do you feel like you could get the edges, the margins?
Well, I was going to say, I would accept vismodegib as a neoadjuvant strategy within a clinical trial, but otherwise my two treatment strategies for a more superficial cancer in this location, basal cell, would have been a consideration for radiation. But for this cancer, I think resection with a strong consideration for orbital exoneration because of its proximity to the medial rectus within the orbit is probably the most robust option but certainly one that needs to be discussed carefully with the patient.
Yeah, well, that's the tried and true, and nobody can argue that, doing a wide local excision with adequate margins and sacrificing what needs to be sacrificed is very reasonable. But let's see. Kevin, what would you do in Boston?
I'd like to, before we move on, let me make a comment, please.
Sure.
So yes, we have experience with using hedgehog inhibitors in a neoadjuvant setting. I think in this situation, though, if you do that and then you anticipate radiation to follow to control the disease, you're going to have to give full dose to the orbit, and you're going to have not only loss of vision but a painful globe. So it's not really a great option here. So you could treat the patient with a hedgehog inhibitor to the point where they begin to progress, and then definitive surgery with likely post-op radiation. But I would not favor trying to control this with radiation.
One question for you, Dr. Weber, since you said, if you do a hedgehog, what's your strategy? Do you wait until it doesn't respond, or you just do a neoadjuvant and after it shrinks, you just go ahead and take it out? And what one margin would you take?
Well, I think you have to base your margins on your clinical exam at the time of surgery, but also guided by imaging. But this would need clearly an orbital exoneration and a flap. I'd also want to make sure the skull base is free. There could be involvement of the ethmoids here, and so you have to carefully exclude extension to the skull base. As far as the hedgehog, my experience personally in my practice is somewhat anecdotal, but I have 2 patients that would have required pretty much horrendous resections. And we've treated them with hedgehog for several months, get a really good regression or stabilization. But then frequently they need a rest because of the side effects, and we give them about a 3-month break and restart. And so we've been able to at least stabilize, if not control their disease with that approach.
And would the surgery ever get in if the patient, let's say, patient had a good response, but then you have the side effects, and now it's a manageable tumor, would you consider surgery at that point, or try to do more hedgehog?
Yeah, I would consider surgery at that point. And if they begin to progress, then the drug's off the table at that point. We would proceed with standard therapy.
I was just going to say that I agree with what Dr. Weber's saying. At least for Aravich, the package insert is now saying that an acceptable dosing regimen is 12 weeks on, 8 weeks off to make the side effects more tolerable. They're about to publish that data in peer-reviewed journals, but that is forthcoming. And I think it's helpful to have a break.
Excellent points all around. Kevin and Mike, do you have any comments?
I think I would get a second opinion from an ophthalmologist because I can't imagine that has 20/40 vision. But because I think that's a really key point, what exactly his orbit function is, because even if he has great regression, he's probably not going to restore function if some of that medial rectus is truly destroyed. And so even if you have a complete response, what kind of function? I think that's the key in making these decisions. I think the second key is, Dr. Weber was alluding to, that making sure this is really anteriorly based, because you don't want to miss out on something that's posterior, that you only have a small window of resection, or something going into the skull base. And I would echo the same thoughts. Our experience with vismodegib in particular has been some amazing responses and some not so perfect responses. And essentially everybody gets side effects, and oftentimes not till about 2 months. They think this is going to be amazing for the first 2 months with really minimal symptoms, and then they set in. So almost everybody needs a break.
Okay. Mike?
In the interest of time, I don't have a lot to add to what's been already discussed.
Yeah. So if I was going to summarize this, go ahead.
Yeah, I've got a few more slides, so let me move on quickly.
Okay.
So I did offer him surgery because I was concerned about the function of the orbit, even if he did have a good response. He saw our medical oncologist and ultimately elected for vismodegib. This was him at 6 months. So he's had pretty substantial involution of the tumor superiorly. He does have still some gross tumor inferiorly down along the lacrimal sac. At this point, we again had him addressed by ophthalmology. Again, his vision was still about 20/40. Again, he still had the same persistent limitation of his extraocular motions. Discussed surgery. We discussed resection at that point. Again, he elected for, this was an MRI scan, basically reduced tumor volume. And I just want to show you what he looked like then after 6 more months of vismodegib. So he was on for now 12 months of therapy. This was actually just last week that I saw him. And he now has what looks like gross total response, really not biopsied, so I can't say pathologic, but certainly a gross total response to therapy. And here I can show you kind of what his extraocular motions are. Here you can see medially, his medial gaze is okay, but laterally he's completely restricted. The eye, really, he doesn't function with this eye. The lid stays down. He's also describing a lot more pain in that eye at this point, and he's having just persistent epiphora. So a good illustration of basically a preserved eye with a gross total response to therapy, but really what I would probably consider a non-functional eye at this point that is causing him pain.
The pain might be just a dry eye because he really cannot close that eye, and that's going to cause some problem. His tear ducts are probably pretty messed up at this point. Now, would you consider seeing an oculoplastic to do some a little bit of a recon, especially for the lower lid?
Yeah, so I was interested to hear people's thoughts here, whether they thought this was salvageable or whether they would offer just normal exempt at this point.
Okay, well, we will discuss and then we'll send you the bill or the state of California. Okay, well, Dr. Weber, what would you offer this patient at this time?
I still don't think you've necessarily controlled his disease. I think you'd have to follow him. So trying to do something with the lid at this point would, I don't think, be very successful or advisable. The upper lid's definitely much harder to repair than the regain function, and it's more important than the lower lid. I'm concerned about the lateral rectus. That suggests he's got perineural invasion because the tumor was more medial. And basal cells, particularly these that are invasive and aggressive and the infiltrative type, are associated with perineural. So you don't want to let this go and then he's got intracranial disease. So I still don't think we're over the hump with this patient.
How often would you repeat the MRI or any other imaging for these cases when you're watching?
Yeah, that's a good question. I don't know, maybe every 3 to 4 months, maybe every 6 months. But if he didn't have a lateral rectus involvement previously, and he does now, I'd really want to know why. Is this a muscle involvement or is it restriction medially? I think there's a lot of reasons. You got to sort it out with the ophthalmologist.
Yeah, excellent points. Kevin and Mike, what would you do?
Yeah, I totally agree with Dr. Weber's comment. I worry about, I don't know if this is a larynx equivalent. The organ is there, but it's not really helping him. Doesn't have, usable vision, and still at significant risk. He's a young, healthy guy. He's going to be around for a while. So I would certainly consider extensive surgery and definitely close watching. I worry about those medial and lateral rectus findings as well.
Yeah. So in the interest of time, I'm just going to summarize this real quick. Who's this? Sorry.
I was just going to say the ophthalmologist can do a needle biopsy into the muscles to see if there's residual disease. Yeah.
So a couple of points just to summarize the case. I think all of us here are sitting and kind of have a bad feeling about this in the back of our mind, because right now, as everybody alluded, this is curable disease. Granted, will require sacrificing the eye. The eye is barely functioning. You could do that and get rid of it. And the difference between curable and incurable, as Dr. Weber and Kevin mentioned, is very thin. The moment this gets to the brain, the moment it gets to the skull base, then you're talking about probably an incurable disease. So those are the points that you have to consider. Nobody likes to take people's eyes out, but if that's going to save their lives, you may want to consider it. Very quick question. What kind of recon would you do or recommend? Kevin, Mike, Arno, anybody who does recon?
I would fill this with soft tissue, probably a forearm, and then I'm fortunate to have an amazing prosthodontist that can make this, create a platform for that person and put a prosthesis on it, it would look better than it looks now in many ways.
Yeah, absolutely. Forearm, okay. One vote for forearm, Mike.
Yeah, same thing. We're doing the exact same reconstruction tomorrow. Yeah, I just usually base the skin pad a little bit more proximally on the forearm, and then you just use a distal soft tissue, kind of like the reverse of a beaver tail, where you just put the fat and fatty tissue back in the orbit itself, and then obliterate the front with the skin paddle for monitoring purposes.
Arno, what would you recommend if you are doing this?
Yeah, I think particularly with the involvement, with the communication with the lacrimal system, you're going to have an open hole into the ethmoid sinuses, into the nasal cavity. So I think free tissue would be required.
What's your choice?
Forearm.
Okay. Dr. Weber, what would you do in the Indiana? So what's the preferred mode of treatment?
We might use an ALT. Forearm might work also, but you're going to have, you need some bulk here. You can always debulk it later, but that'd be the two options, I think.
If you're doing the resection, would you take the bone as well, or which part of how big of is your resection if you would just for this case?
Wide on the skin, the orbit. I'm concerned about the supraorbital rim a bit, and maybe and also the lateral nasal wall and ethmoids. I'd need some more coronal imaging to look at the skull base to see if that's involved as well.
Yeah. So that's the point that I wanted to make sure that everybody knows, that before you commit to surgery, it's a very careful review of all the imaging is extremely important, because sometimes you might need to do more than you think you need. All right. Okay, Dr. Emmerich, your case up.
All right. Let's see here. All right. Everybody can see this okay?
Yeah.
Excellent. So this is a 53-year-old guy with a pretty boring history, which a lot of initial melanoma patients have a pretty unexciting history. But like a lot of patients, he's had a longstanding pigmented lesion for about 2 years. And then with some really classic symptoms that it recently got a little bit darker and started to notice it was bleeding. He's otherwise a generally healthy guy, and actually no previous history of any skin cancers yet. So, and for Dr. Chang, she actually sees primary melanomas. This is more often how we see them post biopsy, without a whole lot of excitement there. So you know, the fellows need to look in the textbooks to see what melanoma looks like sometimes. So, and he showed up with this path report. Melanoma, at least 2.35, ulcerated, and 5 mitoses. I think, you know, for the fellows on, this is a pretty standard synoptic melanoma report. And I think it can be a little overwhelming sometimes when you first start seeing melanoma patients. And so what I would encourage you guys to start thinking about, and anybody else chime in if there are other key foundations for you, but for me, I really focus on 3 things. I focus on the thickness, whether or not there's ulceration, and any mitoses. And then you really got to pay attention and see if there's any of these comments like at least, meaning the biopsy didn't quite catch the full thickness. I don't know if anybody else has any other important things on their synoptic report beyond that.
What Dr. Chang, what would you want to see in the synoptic report that might change your management?
Let's see here. You've got breast low depth. So basically, it's from the stratum corneum down to the deepest tumor. So I'm assuming that's basically the words breast low depth is what I'm used to seeing instead of maximum tumor thickness. But I'm assuming that's what that is. And then, you know, it used to be ulceration was part of the staging. It seems to be a secondary kind of factor now, but that's good to see. Mitotic rate, the 5 is kind of on the high side. Lymphovascular invasion. So pretty much all that stuff is there. Also, there'll be some subjectivity, like what type of melanoma. superficial spreading, nodular. Some have more desmoplastic. Some have a more aggressive type of subtyping. So it's good to know that as well.
Dr. Weber, what the standard in the MD Anderson for melanoma reporting in pathology or for biopsy?
This looks good to me. We use a synoptic path report. I think this looks very complete.
Okay. Any other comments? I think I agree. This looks pretty good, Kevin, whoever was the pathologist.
Yeah. So, putting it out to the panel here a little bit, would anybody do any additional workup at this point? This is a T3B lesion. On physical exam, there's no palpable lymphadenopathy. On a systemic review of symptoms, there are no symptoms. Would anybody get any additional workup at this point?
I would.
What would you do?
I do a couple of things. One, and maybe it's a bit controversial, but I would definitely do ultrasound of the parotid and neck, because if you see a node that's worrisome and they FNA it, and you don't really need to do lymphoscintigraphy and lymphatic mapping. So I do that. I guess other imaging would be optional, but ultrasound is a good screening tool.
Yeah.
And I would do lymphatic mapping if the ultrasound's negative, because we are going to do a sentinel node biopsy on this patient.
Okay. Perfect. I agree. I think ultrasound is an excellent idea. Sometimes we don't think about it outside thyroid, but as Dr. Weber said, it's quick, it's cheap, it's no problem for the patient, and it actually a lot of time will give you a lot of information.
So I think for the T3B and up patients, it's reasonable to think about it. But I think technically the NCCN guy, and that's who I take a very similar approach. But for the fellows, sometimes the NCCN guidelines I think suggest actually not do anything. But this patient, I got a PET CT because of that T3B status, the ulceration, and relatively thick, knowing it was at least 2.35. It was also at the beginning of COVID, and so that helped us with some of his management issues. And the PET CT was negative. And so we recommended excision and sentinel node biopsy, which I think is pretty straightforward. If nobody else has any major things, objections to that approach.
Kevin, I'll just make a quick comment. I go with the at least 2.35 and I take it at face value. Sometimes with larger lesions, which I'm sure you do too, if there's really certainty that it's going to be a lot worse than it looks, I would do a punch biopsy or re-biopsy to get a full thickness evaluation. But in this lesion, it looks like it's very focused and big piece. The biopsy took out a big piece of it. And I also agree with, I usually do a CAT scan for the lymph nodes, even in T3 and T4. I know, but I agree the NCCN guidelines are sort of not usually recommending imaging, but I think imaging of like the inguinal area or the armpit is a lot less valuable than like a CT neck. So that's where I think that how I justify that deviation a little bit.
Sure. So before we move forward, I agree. Okay, in terms of excision, let's ask people, what kind of margin would you take for this? Jeff, let's start with you.
All right, can you go back to the picture?
2.35.
Oh, yeah. So,
a little bit of pigmentation left through here.
A little bit of pigmentation. Thank you.
For, there are very formal recommendations for excisions for T3, T4. I think it's either 1.5 for T3. I think it's 1.5, and T4 is almost like 2. But this is like, on the back, it's real easy. This area is particularly easily resectable. When it's on the cheek or near the eyelid, you start to, see what you can get away with. Or on the scalp, certainly. So here, I would favor between a 1 and a 1.5 centimeter circumferential margin from the farthest edge of what I can see of the pigmentation. You have to really look at the patient's skin very carefully, because I've certainly gotten burned where the melanoma in situ at the edges really progresses. Extends out a little bit, and you want to try to make that the edge of where you start measuring, because a lot of times you can see melanoma in situ on the microscopic final margins. And then you have to go back and consider re-resection.
So on a good day, 1.5, on a bad day, 1 centimeter.
Yeah.
Okay.
But here, I think you have a lot of room to go, and I would, you can be generous.
Okay, Mike and Arno next, and then we ask others.
Yeah, I agree. Same. Probably do 1.5. I imagine the points of the timing of reconstruction. Is that going to come into the discussion, Kev?
Not really.
Yeah, so
Well, we can.
a lot of times I will, at least a lot of that's institution dependent on how much you trust margin assessment intraoperatively. At my institution, I do not trust melanoma margin assessment on the day of. Similarly, we don't have a regimen that's very helpful as far as on the spot sentinel lymph node evaluation. We do sentinel lymph node biopsies, but wait for permanent. So for one like this, I would consider placing a bolster and get final margin status and lymph node status before determining.
Let me make sure I'm clear. So you would take this patient to the operating room, do the sentinel node, take it out to 1.5, and just leave the wound open, waiting for the final pathology for both the sentinel node and the specimen. Correct?
Correct.
Okay. Arno, what's going on in the UC Davis?
Yeah, nothing really new to add. I think, yeah, just the important point that this is a forgiving area. You can reconstruct this really nicely with probably cervical advancement flap. So I wouldn't go short on those margins. I'd go 1.5 to 2 centimeters.
Dr. Chang, what's the dermatology recommendation for this?
Wow.
1.5
So
or 1 or 2?
we don't do them ourselves, but with ulceration, it can be, NCCN says 2 centimeters. This one doesn't have ulceration, so maybe 1.5.
Okay. Dr. Weber, what's the routine at the MD Anderson in terms of the conduct of the operations?
I think it's very similar. I think that was Mike that described the margins and the sentinel node. And we do delayed closures on these because I want to know the margins. And yes, I have had problems with melanoma in situ. So we can get a turnaround on those in about 72 hours. We put a dressing on it and then come back for definitive closure, re-excision, or maybe lymphadenectomy if that's needed.
Would you send your sentinel node as frozen, and if it is positive, just do the next dissection right there, or you just don't even send for frozen anymore?
We really get tremendous pushback on trying to do frozens for these, so it's pretty much permanent histologic review.
Yeah, we're like that too. There's a specific protocol for sentinel lymph nodes that require microsectioning and staining. And so, and also the discussion now with MSLT2 is a real discussion whether completion lymphadenectomy needs to happen. That discussion should really happen before. So for us, I always send my sentinel lymph nodes for permanent because there's so much discussion that has to happen, both in terms of the pathological evaluation and the subsequent discussion if it's positive with the patient.
Okay.
Just a small technical for the fellows that when you do these resections, I always resect the primary first, just because in the operating room, the shine through from your injection is very difficult, especially here in the neck. If your lymph node is going to be like level 2A, it can be very hard to see. So resecting the primary first before trying to go hunt for the lymph node is important so that you can, try to reduce the shine through.
We have a very interested head and neck radiologist and nuclear medicine who we routinely do a SPECT CT here. And that's been extremely helpful for us. But yeah, same here. Okay, Kevin?
Yeah, so for the fellows, the take home is frozen, not good for pigmented lesions. And so I did do excision and sentinel node biopsy. For me, anything over 2 millimeters of depth, I do 2 centimeters. I think there might be some data, but we did a 2 centimeters in a sentinel node biopsy. And I want to reiterate the point that Vivek just made. When you do a sentinel node biopsy after the injection, the first thing you get is this lymphoscintigram, which is the historical imaging we've always used. And this is the one for this patient. And as you can see, you really don't see anything.
Yeah.
SPECT CT is critical in the head and neck. I think it's really important. I think it really increases the reliability. And so, yes, indeed, there is a sentinel node that's going to be just deep to this. And if I didn't do the SPECT CT, I wouldn't know. And so for the fellows, as you go out and start to practice, make friends with your nuclear medicine physicians, make sure they're doing SPECT CT, really valuable. So
couldn't agree more.
This was our post-op path report on the primary tumor. Our margins were clear, no additional high-risk features beyond what you saw on that, no satellite metastasis. And yes, that node directly under in the parotid was positive. And these are the times you're like, let's forget it. Let's not do it. It's not going to be reliable. You got all that shine through. And no, we as head and neck surgeons have the ability to do it, and that's why we should be doing these cases. So do it. And yeah, this is a tiny focus, 0.5 millimeters. So for his staging, puts him at a T3B, N1A, M0. If he had not already had a PET CT, really important to do a PET CT here, as well as an MRI of the brain. So an MRI of the brain, which was negative. And I think we can get maybe to some of the other interesting questions about what to do now. And I would say that he has at least a 40% risk of recurrence in the next 5 to 10 years. Recurrence meaning in particular in the regional nodes as well as distant metastasis. And so maybe I'll turn it to the group to see who wants to do something next.
Well, the
Or if there's any-
MSLT2 was easy. Now we have the MSLT2 that shows that there is no benefit. However, if you read the fine print, it was different for head and neck. All right, so let's go around. Who would do more?
So I think there's two major considerations for this patient. One is the role of adjuvant immunotherapy in patients with stage 3 melanoma. And I'm going to post the PubMed link shortly. There's a New England Journal article that showed the benefit of adjuvant immunotherapy. So a patient like this would really benefit. The real discussion is whether or not completion lymphadenectomy would offer benefit for this patient. Summarizing MSLT2 in like a couple lines would say that it doesn't really seem to really affect melanoma-specific survival, but it may have an impact on local regional control. And it also, there is a risk of lymphedema, but that's usually that includes extremity data. So at least in our practice, I would favor doing completion lymphadenectomy. I think it's a low risk, reasonable reward, and I find local regional control to be a real benefit for these patients because we've all seen patients met out in the neck and what a problem it is. So I would advocate for adjuvant immunotherapy with my medical oncology colleague and a completion lymphadenectomy discussion with the patient.
And your completion lymphadenectomy is parotid neck?
Let me think about the site. I don't know about the, probably, yeah, parotid. I have to think about the primary site just a little bit more. If it was in the temporal region, clearly parotid neck. Well, depends on what the sentinel node was.
In the parotid.
What was that, Kevin?
The sentinel node was in the parotid.
Oh, it was. Okay, sorry. Yeah, so it would have to be a parotid neck, yes.
Okay. In the interest of time, we're going to move on. I think that was a fantastic discussion. Mike and Arno, you're next, and then we ask Dr. Weber what they do in the end.
I would agree with what was just said. I would do a subtotal parotidectomy and neck dissection, including parafacial nodes, obviously.
Mm-hmm.
Yeah.
Arno?
Same thing. I think, especially since he's going to require reconstruction, probably a cervicofacial advancement flap in my hands, which is going to expose the cervical lymphatics anyway. So I think you could do a safe superficial parotidectomy neck dissection with little added morbidity. So I would offer him that for regional control.
Okay. Dr. Weber?
Yeah, I think there's three options. One's observation. The other, we have a trial specifically for this scenario where they would get immunotherapy. And the third would be a lymphadenectomy and additional therapy based on those findings. I carefully go over all the options with the patients. And I tell you, I've had patients select all three. Some just said, I want to be observed. I don't want extensive surgery, and I don't want a drug that may cause a lot of side effects. So, and of course, we bring in our oncologists into the discussion as well. So standard therapy.
If the patient says, I do whatever you tell me, what would be your preference in terms of what do you think that to be the most beneficial for this patient?
I'd favor a trial, a high-risk trial for this, yeah.
Yeah, perfect. Okay, Kevin, what did you guys decide?
Yeah, so, you know, I would also add targeted therapy for these patients. He has a BRAF mutation as well. And so our melanoma group here at Mass General, Mass Pioneer, we do not recommend completion lymphadenectomy unless someone's not going to follow up. If you look at MSLT2 as well as other trials, you've got about an 11 to 17% risk of having a non-sentinel node. And almost all of them have distant disease. And so I think the really important thing is the systemic treatment options, especially given the thickness of his primary tumor. And so our group would favor no lymphadenectomy unless you were concerned about this patient not following up. Otherwise, they're following up closely. We can still have good regional control. And we would focus on systemic treatment. And for patients who have a BRAF mutation, we typically would recommend BRAF MEK inhibitor. If he had multiple larger volume positive sentinel nodes, we would probably lean towards monotherapy with anti-PD-1 therapy. But for a patient like this, we recommended BRAF MEK inhibitor. And our
So no PD-L1, just a BRAF inhibitor.
BRAF MEK, yeah.
And no radiation.
And I put this for the fellows just that there's really a very, 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 very limited role for any adjuvant radiation in melanoma. It's got to be a really big node with extracapsular spread, with concern for microscopic disease, and not being a systemic treatment candidate, I think is the very limited role for adjuvant radiation. But just for the fellows to get out of that idea of regional node equals adjuvant radiation.
So we're gonna record this part of Dr. Emmerich's speech and just repeat that every time. So for all the fellows, so any tumor board you go, you remember, because you're gonna see a lot of your colleagues, the moment they see a positive, say, oh, patient needs radiation. And now you heard it from the experts that really radiation in melanoma is extremely limited role. I think that's been the change in most places. Dr. Weber, what's the role of radiation as the Anderson for melanoma?
We use it really selectively. I would say in a patient with a scalp melanoma that presents with satellites, we would give them post-op radiation or a systemic trial. An elderly patient with extracapsular spread, multiple nodes, multiple levels, we might consider it, but it has a limited role, but it does have a role.
Okay, perfect. Yes, and I completely agree that. Okay, Kevin, do you have any last slides?
Yeah, just one thing I'll tell the fellows as you go out into the world, that your melanoma multidisciplinary team may not be the same as your head and neck team. And so make sure you engage them, be a part of that team, understand what the current philosophy is of that melanoma team that might be different from what you've experienced so far. And that'll help you become integrated into those teams. And so key take-homes for you guys, those three foundations of depth, ulceration, mitoses will get you started on a treatment plan. Some of the imaging we talked about, the SPECT-CT we highlighted, the evolving role. I think the most important thing is you can talk like someone who's educated on the literature about the role for completion lymphadenectomy and really understanding the different systemic options in the adjuvant setting that are out there. Really the key take-homes as you guys go out into the melanoma world.
Perfect. Okay, thank you so much. This was an excellent conversation and discussion. I definitely learned a few things. For the fellows who are still on the call, I think we have 38 people on the call. Well, congratulations on finishing fellowship. Years from now, you're going to look back at your fellowship and you always remember it with fond memories. Fellowship is one of the best years of life for most of us. Welcome to the society. Welcome to be part of the brotherhood. It's a fantastic job. It's very hard. It's not going to get easier, but it's still very rewarding, and it's a wonderful career to have. Although you're going to see a lot of horrible diseases, but you can help a lot of people. You're always welcome. Hopefully next time you log in as an attending, as an expert in the panel. We look forward to having you. And we wish you best of luck in the coming months, wherever you end up. I would like to thank you, Dr. Chang, Dr. Emmerich, and Dr. Weber for being our guest. It was an excellent conversation. Thank you so much for taking the time and for your expertise. And I also have to mention my partners in crime, Dr. Jeffrey Liu, Arno Bewley, and Mike Moore, which we really can't do this without them. We look forward to seeing you again next year. Our next session would be in the second week of July. If you are around, give us a buzz. Thank you. Have a great night and have a great summer.
Thank you. It was great cases. Appreciate it.
Thanks, everybody.
Thanks so much.